Good evening, everyone, and a big welcome to the Exploring Endo webinar. We're very happy to have you all here on behalf of the Royal Hospital for Women Foundation. My name's Gabrielle, and I'm part of the foundation team here at the Royal. Before we get stuck into your very important and intriguing questions that you've all submitted, I'd like to acknowledge the traditional custodians of the land on which we gather to share this information and learning tonight, and pay our respect to elders past, present, and emerging. I'd like to particularly extend a warm welcome and recognition to the people of Aboriginal and Torres Strait Islander descent who are joining us here tonight. So tonight we are very privileged and grateful to be joined by Dr. Erin Nesbitt-Hawes and Dr. Jason Chow, both experts in endometriosis, among other things. And we are very excited to bring you this very important information and to facilitate this discussion tonight, particularly since we are in the middle of Endometriosis Awareness Month. For those of you who aren't familiar with the Royal Hospital for Women and what we do, we're located here in Randwick in Sydney, and we're the only dedicated women's hospital in the state. We're fortunate enough to be home to some of Australia's leading experts in all facets of women's and newborn health. A special welcome to any Royal staff here tonight, and thank you for joining us. We really hope that you're all able to take something away tonight, and we've been so impressed with the variety of questions that we've received. We're also joined by my colleague Elise Simmons, who will be facilitating a Q&A at the end of the session. So if you do have any questions that occur or come up while we're discussing the ones you already submitted, please feel free to add them to the group chat or message Elise privately if you'd want to remain confidential, and hopefully we'll have time to cover them off at the end. So without further ado, I'd like to pass over to Erin and Jason, and we'll get the discussion started.
Thank you very much, Gabrielle, and thank you everyone for joining. It's a really excellent turnout tonight, and I would just echo what Gabrielle's been saying. We're really happy to have this opportunity to chat about endo. It is Endometriosis Awareness Month, and I hope everyone's getting out their yellow and wearing it in support of women with endo. And I know that a lot of the people listening today, certainly, through a lot of the questions that we've received, I know we've got a lot of endometriosis sufferers online, but also family members, and we're going to start off talking, but as Gabrielle said, feel free to send any questions through. So I guess I'll start with a little bit of a background of what is endometriosis, because I guess a lot of you might already know, but some of you may not. And it's a condition where cells which are really similar to the lining of the uterus are present outside of the uterus. And mostly, we often see endometriosis within the pelvis around the other gynecological organs. So that might be around the ovaries or down behind the back of the uterus. But really the cells can be anywhere in the abdominal cavity, and in some rarer cases, they can even be present outside of the abdominal cavity in areas such as the lungs. So what happens when that tissue is outside of the uterus? Well, I guess the body recognises it as being foreign and not being in the right place. And we know that sets off an inflammatory local response in the body. And that irritation and inflammation is part of what we think causes pain for a lot of women with endometriosis. In terms of the why does it happen, that's still something that we have a lot of hypotheses around, but we don't have one single definitive answer. So certainly there is a genetic component to endometriosis. We know that there are over 50 genes that have been implicated in endometriosis. So it's not a simple genetic condition, but there's probably a genetic predisposition for women who might have a number of those gene predispositions handed on through their family. And we also suspect that there are factors in the environment that might turn those genes on and off. And that probably also is implicated in whether women actually go on to develop endometriosis, even whether they have the genes or not. I'm going to hand over to Jace, who's going to tell us a little bit about the symptoms of endometriosis, and I'll chime back in later.
Thanks very much, Erin, and again, a warm good evening to everyone who's on the webinar. Thank you for giving up your evening to come and join us. The symptoms are manifold, and I think this is an important thing to think about because there are some more specific symptoms that you would commonly think about with endometriosis, but there are also a lot of associated symptoms that may not come to the fore or that may not be immediately recognised, but they're also important to think about as well. The features that most people would describe include pain, tends to be in the pelvic distribution, but it can be mixed. So it might be for some people presenting with more bladder-based symptoms or bowel-based symptoms. A lot of the time it can be with your cycle, so with the period or around the period time, before periods, or around ovulation, but they can also occur outside of those times as well. Some people may present with sexual pain, and some people may present with changes in other symptoms. So, for example, we see that people present with rushing to the toilet or discomfort or pain with bladder fullness. Other people might present with mixed bowel symptoms. That might be bloating or not just pain, but changes with mixed bowel, loose stools or constipation around period time as well. Erin talked about how endometriosis is often associated with these inflammatory changes in different parts of your pelvis, or can be in other parts of your body. And so we think that, you know, these changes give the symptoms, but we also know that the amount of those changes don't always correlate with the amount of symptoms you can have. So it doesn't always be the case that you can have really severe symptoms and expect to have lots of endometriosis and therefore always be able to see it. Sometimes you can have very small amounts of that endometriosis but have very big symptoms. So the amount of symptoms and the degree of symptoms you have doesn't always correlate. We also see a lot of people with endometriosis have this conglomeration of symptoms. So there are certainly some people who only get period-based pain or sexual pain or pain around the ovulation. And there are other people who have this full change where they get wider spread body pain. They may get headaches, they get vulvar sensitivity. They may get a common thrush, and that is there are some people who will get that more widespread clustering of symptoms, and it's important to recognize that because you might be getting a bit of fatigue and a bit of headache and a bit of menstrual symptoms, and it doesn't all explain by the endometriosis changes in your pelvis alone, but it's important as a starting point to look at it from that broad point of view as well. I think that some of the questions that we've had previously is, you know, I have pain that's outside my period time, or I have these broader symptoms, but I think if you can hear this cluster of symptoms, sometimes this is still suggestive and worthwhile to investigate and look at. My last point would be that no matter what the cause of those symptoms are, if pain is a persistent issue, and particularly period pain, it needs to be validated and looked at. And one of the common stories that Erin and I hear is that story of a long time to get information or access care. And certainly it doesn't matter whether you find, you know, that change in an ultrasound or you actually get that diagnosis of endometriosis, your pain should be managed for what it is. And we know that people who have persistent pain will have changes to their pain nervous system. And it's not necessarily related to endometriosis changes in their pain nervous system, but it can be related to those neurobiological changes. And the more pain you have over time will change the way your pain nervous system processes that information. So earlier management and addressing of that will help prevent those downstream effects later in your life.
Yeah, and I would echo Jason's comment about not just validating, you know, pain, but also, you know, with some people are a bit uncertain of when to seek help and when to, when to go to a doctor, when to say, is this normal or not normal? And I think it can be tricky, especially in some families where a lot of people in the family might have endometriosis, and so there's some normalization of pain symptoms. But if that degree of pain is impacting your life and your function, and you're needing to have time off work, or even if you're just needing to really manage what you're doing around your cycle, changing plans because you know that you're going to be in pain at certain times of the month, then that is certainly to an extent that we would consider to be not normal, and that needs, you should feel validated that you can go and ask for help. And if the question of endometriosis isn't being discussed by the doctor that you're seeing, you feel free to raise it, because those are symptoms that, when they are really affecting your quality of life, that's where we're really hopeful that we can make an impact and, make a difference, and certainly improve functionality. Once people come and see us and we see a cluster of pain symptoms, like Jason was talking about, and I just will also note that one of the symptoms that sometimes women will present with is infertility and fertility issues, and we're going to talk about that separately a little bit later. But one of the things that we'll look at is how to diagnose then endometriosis. And I think endometriosis is unfortunately a really tricky disease to diagnose. We have a gold standard of diagnosis, what we consider to be the best diagnostic test, which is a very, very invasive test. It's an operation. It's a laparoscopy, which is keyhole surgery. That allows us to have a look on the inside of the uterus, inside of the abdomen, and visualize endometriosis and actually remove lesions. But a laparoscopy isn't required by everyone to be given a diagnosis of endometriosis. So while it is, the gold standard, not everyone who presents with all of the symptoms of endometriosis necessarily needs to embark on the path of having a laparoscopy. And things have definitely changed with a view to that being an early option for diagnosis for women. Certainly one of the other ways that we now have of diagnosing endometriosis, which has been really helpful, is the utility of ultrasound. And we've got really specialist women's health ultrasound practices who do deep endometriosis ultrasounds, and that might help us see endometriosis on ovaries, or even endometriosis that's attaching, organs together and sticking things together. And more frequently, we're starting to see even smaller volume of endometriosis can be diagnosed on ultrasound, which is really exciting to see, because it allows us to make a non-invasive diagnosis in more people. But also we have a clinical diagnosis of endometriosis. So when people come to Jason or myself or our clinics, and there's been pain with periods since adolescence, there's a pattern of pain with sex, maybe bladder irritability, and everything is leaning towards and looking like endometriosis, then actually I have no hesitation of giving patients a diagnosis of endometriosis in that kind of scenario, because part of what we want is to be able to give people something that they can then be working towards in terms of treatment. So surgery is not necessarily an early diagnostic option. It is something that sometimes we use, obviously, but more as in diagnosis and treatment, I would say. Yeah, is that what your feeling is as well, Jason?
Yeah, I think absolutely. I think that if we went back and we had this same webinar, if we had opportunities to have webinar 10 years ago in the same way, we probably would have been talking more about doing surgery and getting that surgery done early. And you might still hear that, and I'm not saying that's an invalid thing to do, sometimes it isn't appropriate, but I don't think it needs to be your first treatment. You should be treated for who you are at the time that you present. And so if you present with those symptoms, we should start managing it in that way. Now, one of the challenges we sometimes hear is that because of those system changes, and we're sorry that some people experience those system changes of invalidation, you feel that the need for the surgery is there to be able to validate the symptoms. But we also talked about how the amount of endo you have doesn't necessarily correlate. And so this can sometimes end up being a bit of a double-edged sword, that some people say, well, I've had the surgery, there was small endometriosis, so it doesn't correlate the amount of symptoms I have. And that's where it comes to it, is that it doesn't matter what the volume of that endometriosis is that you see at the surgery or on an ultrasound, we should still be more actively managing who you are for what you're coming to see and get help with. And so by the same token then, it's important to help manage regardless of that. The other issue in that sort of setting then is for people who do end up with having surgery and may or may not have improvement with it. We do find that 70% of people who undergo surgery will have an improvement, but that can be variable. So that means that 30% don't always get the improvement they do from surgery, and that might be reflective of these other mechanisms behind their pain at that time. It also might not be completely durable, and then that leads to these tricky questions about, do you reoperate or versus do we better help you manage where these things are at? I don't know, Erin, if you wanted to speak a little bit about that scenario where you might have had someone you've seen who might say, I've done the surgery, you may have done the surgery, you and I may have done the surgery as well, and they're not seeing as much benefit as they'd like to see.
Yeah, absolutely. And I think the way that I think about endometriosis and symptoms of endometriosis is really trying to look at the patient as a whole with a condition that is causing inflammation and irritation, and that's the endometriosis part of it. So we might manage that part with some surgery or with some hormones, and that can have variable impacts. But often we see that it's multifactorial, and that those people might have, as a result of a chronic experience of painful episodes over and over again, they get muscle tightness and overactivity within the pelvic floor. So often, and I'm sure you're the same, Jason, like most of my patients with endometriosis have very tight, tender pelvic floor muscles, and it's an area of the body that I think that we're not necessarily as aware of or engaged with, but so many people actually benefit from having women's health physiotherapy or pelvic floor physiotherapy generally, really, to help those muscles maintain more relaxation and to kind of get control over what the muscles are doing. Because if the muscles are tight and tender, it's like anywhere else in the body. You might have a lot of tension in your neck, and you'll get headaches and neck pain. And so we do see that a component of pain can be related to muscle issues. We might need to treat those. And as Jason alluded to, a lot of people actually have changes within their nervous system, and a sort of over-sensitivity or an overreactivity of the nervous system, and less of a capacity to dampen down some of the signals that our brain normally manages from our body. And sometimes managing that aspect is a really important thing when we haven't got the benefit that we want out of surgery. We start to think, well, what else is going on? And I think of it like a little pie, and I always try and manage all of the parts of the pie, and that might be dietary things, and there's lots of things that we can try if surgery hasn't been successful. Yeah.
And you know, to point to that note, sometimes when Erin and I speak to people, they give us feedback. They say, look, you know, are we not validating your symptoms because we're saying that there's neurobiological, these, you know, pain nervous system changes are there, and we're not trying to say that there's two parts of your body. There is this sort of pain nervous system part and the endometriosis pelvic part. They are intertwined. And we know that, again, we don't do one or the other. We need to do both of them at the same time. Give you some examples, and Erin's probably heard this so many times when I've done talks together with her, but, you know, people who have period pain through their life, if you went and tested their pain nervous system, so sometimes we'd put a same hot object on their shoulder at the same pressure, and you did that to someone with period pain and someone who didn't have period pain through their life, the person who had period pain would feel more pain at less heat on their shoulder than the person who doesn't get period pain. So a completely different part of your body. And when we do these trials and looking at people, for example, who we do MRI scans in an academic point of view to look at the parts of the brain that line up with pain messaging and that pain nervous system changes, the people who have endometriosis and pain, or even pain with endometriosis, will have similar changes. And the people who have endometriosis but have no pain have more protective factors in their brain and spinal cord. So these changes are more systemic. We think about the pelvis because that's where a lot of our symptoms are centered, but actually we are looking at you as a whole person in that sort of setting as well. And so it's not one or the other. Often we're trying to co-manage that.
And obviously we've sort of touched on the surgical side of things, but one of the big ways that we might want to target the actual endometriosis lesions themselves and try and reduce the amount of symptoms that people get with those lesions is using hormone types of therapy and treatment. So those are things like the contraceptive pills. Those are things like the hormonal IUDs, so the little devices that go inside uteruses. Even in some cases, we use hormones to try and switch off the brain sort of component that drives the ovaries to produce hormones. So we're almost mimicking a menopausal type of state to really reduce any of the activity that's within lesions. So hormonal treatment forms a big part of how we're actually looking at managing those endometriosis lesions and a lot of the symptoms that people get with endometriosis, because hormonally we can often change a little bit the way that the cycle, the reproductive cycle functions, and that helps reduce activity and reduce inflammation within those little areas of endometriosis. And I kind of think of it like your normal cycle is a bit of a roller coaster. You get all of these ups and downs of hormones at various points of the cycle, and that's your body's way of aiming towards reproduction, really. But for endometriosis, that roller coaster actually drives activity within those cells, and it increases inflammation and those irritative symptoms. So if we can, using hormone treatments, keep things really stable with the hormones so that there are less ups and downs, for a lot of people, that can actually really help to improve symptoms, and it makes endometriosis very quiet and less active, and with that comes a reduction in pain. Now, of course, hormones are tricky because they don't suit everyone easily, and some people tolerate them really well and do really well and respond fabulously, and that's great, and some people don't tolerate them at all, or tolerate some far worse than others. And so there's sometimes a bit of a strategy of trying to trial a few different options to see, because everyone's individual response is going to be different, so to see if we can find a hormonal treatment that might work. But in some cases, we try all of the different options that we have available to us, and then we still can't find something that's really suitable, and that's always tricky, because part of why we also want to use hormone treatment, apart from just managing symptoms, is that it can also just slow that kind of progression of disease. So we might use it to keep a lid on things and hopefully extend out the window of potentially needing to redo surgery. So did you have anything else to add there, Jason?
I think just want to emphasise, I mean, one of the messages you're hearing, we keep talking about seeing you as a whole person and managing things holistically, but the other aspect which Erin's been mentioning is treating you as an individual. And I think you need to individualise or personalise the management. So the hormones certainly work, but you've got to tailor to what works for the person. You might have specific conditions that include headaches or migraines, for example, that mean there are certain types of hormones that contain estrogen you can't have. You might be what we call progestin intolerant, and that might be you get mood issues or other side effects or a lot of nausea and vomiting with that other aspect about the progestins. And so we try to tailor the type of treatment according to that person. And I've certainly, and I'm sure Erin does as well, have lots of patients who just say, I can't do hormones, and we work around that and look at other ways to help manage cycle symptoms. Some people find that, and speaking to people who may have been 10, 20 years ago, or even now, be seeking this diagnosis and told, look, I'll just put in a pill without actually addressing the issues around endometriosis. We do know that we still need to look at the endo and you as a person as a whole. But one of the things that the progestins do, as Erin says, is actually helps reduce the blood flow and the inflammation. So it actually helps prevent that disease from growing or from coming back after you've had surgery. But just because you can't take it, it doesn't mean that that's the only thing you can do. And certainly, if you've had surgery, two-thirds of, a third of people may have a recurrence of endo, but that by flip side means two-thirds of people don't necessarily have a recurrence of endo over a 5-year period. So we, again, would individualise and personalise what that treatment would be for that person.
Yeah, and a few of, I guess, sometimes what I hear from the patients that I'm looking after is a little bit around, with hormone treatments, doesn't that just mask what's going on? And, are we really doing something proactive, or are we just kind of putting a little Band-Aid on things? And I usually talk a little bit about how they work and why we're using them, because yes, they work for symptom management for a lot of people, but they're not just a Band-Aid measure, and they are quite useful, but they're not always for everyone. And I think one of the other things that we were going to talk a little bit about, which I guess is also something that a lot of patients do ask questions around is with surgical management. When we are doing a surgery for people with endometriosis, should they be having excisional surgery where we're actively kind of cutting out lesions? What about ablation surgery where we burn the tissue so that it destroys or ablates those cells, and what's better? And certainly there's some good quality evidence out there to show that there's really not much difference for people in terms of whether you've had excision surgery or ablation surgery. There's a lot of chatter out there about it, but when we look at the trials that are done and the studies where we're really ruling out all of the other factors that might come into play when we're doing surgery, we do find that things like the response to period pain is actually not different for people who have had ablation surgery versus excision surgery. There's been big groupings of studies together, what we call, meta-analysis of different studies to bring them together to try and give us even more information that confirm that that there's not much difference. Now, you will come across lots of surgeons who say, oh, I'm an excision specialist and that's what I do. And Jason and I and a lot of the other people who manage endometriosis have excision as part of the tools in our toolkit. And when it's appropriate to excise endometriosis, we excise it. And when it's appropriate to ablate endometriosis, we ablate it. And that doesn't mean that you're getting a lesser surgery. So I just would reassure people about that. Endometriosis surgeons usually will use a combination of the two to treat. So you don't need to be worried necessarily if someone tells you, oh, you've had ablation surgery.
Yeah, I think to emphasise that point, because this is quite a hot topic, I think we see that patients discuss, and again, we come back to that idea that we want to personalise your treatment, and we want to personalise your surgery for someone who is young and has pain, but may also have some fertility concerns. I think, I certainly would operate differently to how I operated 15 years ago. I would be probably less aggressive with doing ovarian-based excision or removing and reducing egg counts, and Erin would do the same. You tailor that sort of approach versus someone who had a very specific pain that was related to endometriosis, where things might be stuck together, and in that circumstance, it might be better to remove that area of endometriosis where tissue organs might be stuck together. So you tailor the surgery and the approach you do according to your patient. You don't look at the ultrasound or look at what you see at the surgery and do the same operation for every person. You should know what that person is experiencing and what the goals of that person are before you walk in and have that plan with that surgeon. The other thing that I would encourage, if it's possible, is that when you talk to your doctor, your surgeon, your specialist afterwards, is I think they have a right to be able to have a look at your images, have a look at the results of your surgery, and know how extensive it was, what was done, and which areas were endometriosis. And sometimes we talk about this staging of endometriosis, and I think that knowledge for you is really important. I know certainly Erin and I try to do that with all the people that we work with, so that you can go away and know what you've had done, but also if fertility, for example, was part of that issue, you also know what the implications would be, even if you're not planning to have family at that particular time. And I know not everyone in the audience tonight might be thinking about family, and that's not to suggest that's the case, but it's sometimes good to have that knowledge if that is a consideration for you, to know that at that time, rather than be sitting in doubt over years since you've had the surgery. So we talked before about pain not being correlated with the amount of endometriosis you have, but we do see that fertility is associated with the amount of endo and where it is. And so knowing about that and having facts about what's involved and what the implications are will help both your treating team, but most importantly yourself, and will help obviously reduce some of those fears about what is needed. We don't want you to have to be driven towards unnecessary treatments because of that nebulous idea of infertility.
I think that probably leads in a little bit to talk about fertility and endometriosis because, again, as Jason would attest, it's something that often people are asking us when they come and see us, and often it's not an immediate concern, but it might be what about my future fertility and will that be affected? And we know that for some women or some people with endometriosis that fertility will be affected, and it's probably in about 1/3 of people with endometriosis that they might have some struggles with fertility when the time comes that they're trying to conceive. The other 2/3 will try and conceive and will fall pregnant happily. And so I always try to be, more reassuring than not, because everyone's still got a majority chance that they will have no problems. And we usually will give everyone the benefit of the doubt when the time comes to try conceiving. So it's not just because you've got endometriosis that you're automatically needing to have IVF assistance to get to conceive. And I usually encourage all of my patients to conceive naturally as a first step, unless there are other factors involved, such as age, or as Jason said, sometimes the extent of the disease might mean that we want to be a bit more proactive about trying to fall pregnant. If there are then concerns around fertility, and for most young people who are trying to fall pregnant, we give you about a 12-month window in which you could fall pregnant, and that would still be considered quite normal, even for people without endometriosis, to take to conceive. So it feels like a long time at the time sometimes, but if age factors aren't a concern, then a year is usually what we aim for. Now, there may be other factors involved, such as being off all of your hormones and suddenly having all of the symptoms that maybe, drove you to getting a diagnosis back at the start. And some people can't manage 12 months of having periods with no control, and certainly that would be an indication where we might be more proactive and consider things like surgical management. And surgery is useful for women who are trying to conceive and who have endometriosis. We know that it helps to improve fertility outcomes for people, especially if they've never had surgery before. The good news is that IVF also increases or improves outcomes for people who are struggling to conceive. And often the degree of benefit when we look at having a laparoscopy and excising endometriosis versus going straight to IVF and having fertility treatment, they're about equal in terms of their effectiveness for each individual person. But there might be other factors that make us encourage people to go for one option first or the other one. Anything to add, Jason, that I haven't discussed?
No, I think again it's that same message we've been saying. Again, you personalise that aspect of your treatment as well when you're thinking about fertility. So, for example, if you're 40 and there is possibility of endometriosis or some small signs of endometriosis on your ultrasound, but pain is not a big concern for someone like that, and where time is a factor because we know that the egg reserve is potentially lower, you might move towards IVF over doing surgery, for example. Whereas if you had as an alternative, someone who had a lot of bowel-based pain or pain with sex, and you had a correlation of knowing that that was associated with endometriosis, time wasn't a factor, you might have been younger, then you might look at both managing pain from a surgical point of view over going straight to doing IVF at that particular time. You tailor what we do according to what your goals are and what you're looking for doing. And I think on that point where Erin talked about during that time when you come off your hormones and you're trying for a pregnancy and things are harder, one of the things that both Erin and I try to do is before that time where there's an opportunity before you come off the hormones, we often review with you what's your plans and what are your goals. And if we can already identify there are things that we can symptom manage better or can predict when you start getting your periods again, we'll try to manage that. And that might be foreseeing, for example, dietary things or doing physiotherapy in the basis and the lead up to actually trying looking at non-hormonal things that can help manage your pain at the time of when you eventually come off your hormones to be able to help with that. And so often we see this, you're hearing this other message, which is we work together with the team, and often it's this meaningful people in your team, and everyone's team looks different, who are the people that are going to be working with them. But that team of people, we want to try again, tailor, but have support you. So it's not just a surgery, a hormone or an IVF option. It's looking at, again, what are the things that you are trying to work with and working with those issues.
Yeah. What about egg freezing, Jason? Why don't you talk about that? Because that's another question that I get asked a lot. What about egg freezing for people with endometriosis?
Yes, so throw the spicy one, the spicy questions, Erin. They'll get spicier as it goes on. Look, egg freezing is an option for future proofing, where we know that women or people generally who over time will have a decline in the egg numbers. We know that even without endometriosis, that's obviously a factor, and certainly in your mid-30s, we know that will decline. We know that if you have endometriosis, that shifts a little bit earlier, but again, any endometriosis does have a particular stage or the amount of endometriosis, and particularly if you have ovarian endometriosis, we know that that will shift earlier. So if we can identify that early in the piece in your journey, then that might be something as an option to talk about, but it doesn't mean that everyone who has endometriosis needs to get egg freezing done. Often it's a discussion that we talk about for people as maybe they're approaching around the 30 years old, if they're thinking about a family and they're not in a position to try or don't want to try. But it's not that you have to have that done. The other select circumstance is that if we know that there is ovarian endometriosis, we might be a bit more proactive about planning that. And there's some arguments both ways, particularly if you are looking at surgery, that some people may talk about egg freezing even before you have surgery for some people with a bit of ovarian endometriosis or with a good component of ovarian endometriosis, because we know that sometimes the surgery itself may reduce egg numbers as well, and trying to balance that decision making up. Again, it's an individualized discussion, but it's not that everyone who has endometriosis must get egg freezing done. We also, the big question from a broader point of view is that one of the things that we're seeing over time is that a lot more people are getting egg freezing, but we don't know all the long-term data about how many people who get their eggs frozen will eventually use them and take home, eventually have a pregnancy and take home their baby from that point of view. And so we need to tailor it up against the experience and the cost of egg freezing as well. And we appreciate that some of these things are not always able to be done in a public hospital setting. And so again, you've got to individualize the pros and cons, both from the risks of the hormones or how the hormones may make you feel, particularly if you're a person who might be susceptible to side effects of that, and also the financial cost of it, and weigh that up against what you want to do. So again, it's having a discussion and individualizing it to your.
Absolutely. Okay, I think one of the things which we've probably covered a little bit already, but is a little bit about, okay, well, what might longer term management look like? How do you gather your team around you? Where might you go if you're not really feeling that your either concerns are being addressed or your symptoms are being managed at the level that you're at? And look, I think there are certainly lots of different pathways for people with endometriosis, and both Jason and I work in clinics here at the Royal Hospital for Women where anyone can come. It's a public clinic, and we see lots of people from Sydney, but even much further afield with endometriosis. So there are lots of centres like the Women's Hospital in terms of hospitals around where there are experts in endometriosis. So while we're the only women's hospital, but there certainly are lots of endometriosis specialist units around. And so that should be something that through your GP, you should be able to be linked up with a team that do manage endometriosis on a regular basis. And I think if you're not happy with the team that you're with, then, you know, definitely ask and see if there's any other options available for you, because at the end of the day, you need to have your management tailored to you. Now, that's not to say that coming to see Jason or I is going to cure all of the symptoms and be able to manage everything that's going on. But hopefully more and more we are helping to inform people and train other units that a multidisciplinary approach is so important, that the physiotherapists are vital. We often have a dietitian or a nutritionist who we could send you to talk about some of the dietary things that can trigger endometriosis type of symptoms, even though endometriosis isn't really driven by diet itself. And to look at other things like how we can better maybe manage the nervous system changes that we might be seeing. I might get Jason to talk a little bit because he's established the chronic pain service at the Royal Hospital for Women, and that's where a lot of people with endometriosis may end up if they're really struggling with being able to manage their symptoms through the usual channels. So Jason, what sort of people do you see, and what might be some of the things that you manage?
Yeah, so we see a lot of people who may have had other treatments and not found that it's made a difference to their pain. We also see people who've unfortunately may not have been treated as well as you may have had that expectation, and that's challenging as well. And so we do see people who may have not been done the best by the medical system. What we try to do is that, as we say, that message is that regardless of how you present, we want to try and work with you around your needs and try to help. One of the challenges is that sometimes therapies, and that includes surgeries or the medications, can actually cause more harm, and we've got to balance out the risks without trying to withdraw treatments from people. We also know that this is a very stressful disease, and a lot of people have had that story of invalidation or may have had trauma, and that's not necessarily trauma in their life. It could be trauma that's created by doctors or the medical system. And how do we try to manage that and help you work with that whilst negotiating the possibility that you may need future treatments as well, and through the medical system itself. We work together with a physiotherapist and also psychologists. And again, that's not to divide your body up between the biological, the physical, and the psychological. We often see that these shorter therapies around things like mindfulness can be helpful, but most importantly, understanding more and learning skills to self-advocate and navigate the system managing emotional regulation around hormones and spikes in pain can be helpful to better improve your function. Some of this sometimes for people sounds like we're putting things back onto the patient, but what we're actually trying to do is to allow you to be more autonomous, be able to build your self-agency, to be able to self-manage rather than have to be waiting for the next surgery or the next script, really building up your own resources that can help support that. And that's the biggest challenge sometimes in this sort of setting. So we can see that there is this bigger picture that we look at. And again, when we see people in the pain service, it often is at a trickier end or someone who's already gone through a lot of treatments, but we try to, again, look at all those different aspects together with the team. And one of the points we will say is that, you know, people say, well, what are we looking long term and what are we looking at in the future? And I really do think that even though at the Royal we want to help people, but and be able to help as many people as possible, what we like to do is to democratize this, and we want more people to be able to access this care at the community level. And I think this is happening. And we want to also, Erin and I and the team want to put back to you that a lot of the work that's been driven by patients and by people who have suffered and lived with endometriosis is the ones that actually drive a lot of these changes. We certainly want to work with the questions that you have and the things that drive you. And I think you will see that shift in the management, that it's not just at this pointy end, high, in a big hospital centre, but actually that everyone will listen to your symptoms and be able to offer some early management. So you've seen some of that change already with some of the GP centres that have endometriosis centres. I hope you'll also see that there's more information like this or online, and specialists were thinking a bit more of a holistic approach rather than just from a surgical or a hormonal approach. And I think you'll hopefully see that in the longer term as well.
Well, Jason and Erin, this might be a good time to pivot to the final component of this evening, which is the Q&A. And we've had some questions come through that might not have neatly fit into any of the parts we've already spoken about. So Elise has been gathering those and she'll roll off a few questions to you now for the last few minutes.
Great. I'll just start with these two that have come through into the chat. And so if we do have time, we'll cover any more that come through the chat, but I thought why they're fresh. So I guess and again, we do have to answer these broadly so that we can make sure that it's relevant to everyone on the chat. So at what size would you consider surgery a must for an endometrioma?
I think that's a tricky one, and it's certainly it's hard without being able to look at all of the factors that might be going on for an individual person who does have an endometrioma. So an endometrioma is a cyst on an ovary. Sometimes we see that they're very small, they can be a few millimeters in diameter, and sometimes we see that they're very big and they can be 15, 20 centimeters at their very biggest, but often they sit in a kind of mid zone of somewhere between maybe 3 and 10 centimeters. Endometriomas, I would say there's no criteria on size for us to need to excise. So some people are inadvertently diagnosed with endometriosis on ultrasound, but they have no symptoms at all. Maybe they were having an ultrasound for an unrelated reason. Maybe they were pregnant and they were found while they were pregnant. And so in those sorts of people, actually, even though we note that there is a cyst on the ovary and that they then have a diagnosis of endometriosis, it may be that we manage those people quite conservatively because, as Jason alluded to, surgery and operating has risks associated with it. And if we're dealing in a scenario where there are no other symptoms going on, then the risks of doing an operation in that scenario may actually outweigh the benefit. And sometimes one of the concerns that we have around surgery particularly, and that might either be a primary surgery or first surgery in a person who's had no symptoms at all, or when we're seeing people who have had recurrent surgery after surgery after surgery, is that the alterations in the nervous system actually cause an abnormal response to surgery, where surgery can make pain worse rather than better. And that's a terrible scenario for those people who are going through, you know, the sort of recovery and the load of having an operation, often expense of having an operation as well, if it's not within the private sector. And so we are quite cautious. So I wouldn't say that there's a particular size, but we, again, as we've been talking about, we do look at the whole picture. Sometimes what we do is we might monitor the cyst for a while before we decide to do surgery.
And there's been a few come through before tonight and tonight about the possibility of endometriosis returning after a full hysterectomy.
I'll give you that one, Jason.
So I guess it depends what, I mean, we medically be really confusing, use different terminology for different types of hysterectomies, but I guess to put it in everyone's language, a hysterectomy is the removal of the uterus. Some people worry that when we talk about hysterectomy, we're also talking about the removal of the ovaries, and that's not necessarily the case. So usually when we talk about hysterectomy, it's just removing the uterus on its own without removing the ovaries as well. So when people talk about doing a full hysterectomy, if you're implying that it's also removing the uterus alone, there is a risk that you can still get recurrent endometriosis, particularly if your ovaries are still there because you're still cycling. The other issue depends on the amount of endo you had. So if you had very widespread endometriosis, sometimes it's not possible to pick off every pocket of endometriosis without increasing your surgical risks or your risks to the other organs where that is. And this is particularly for people with very widespread or deep endometriosis. There is a risk of that recurrence. But the hysterectomy for some people can be quite helpful at reducing the recurrence risk, so maybe for 2/3 of people. If you remove the ovaries as well, that can be helpful in maybe reducing the hormonal drive. But one of the challenges is that taking the ovaries away can cause a whole raft of other issues. So for some people, particularly when you do this when you're young or even in the postmenopause, it does increase your risk of osteoporosis, early menopause, and that can create issues around your bone health. And you might actually be at higher risk around a low bone density from that in future. It can also make you feel terrible. So it might reduce your energy or reduce, for example, your libido. And these issues might cause other problems as well. So it's again tailoring to that individual what you're trying to seek. Now, the other problem is that some people might have recurrence in symptoms or no improvement in particularly pain after a hysterectomy. And what that's reflecting is, even say for people who've had a uterus and the ovaries removed, really reputable surgeons, and they've really tried to look at taking out most of the endometriosis or all the endometriosis that might be in the pelvis, they may have no difference to their pain. And what that's reflecting is the other organ groups or that turn on your pain nervous system or your neurobiology. And regardless then if you remove the area where the endometriosis is, you've got these alterations that are at a more systemic level. Removing the endo at the pelvic level may not always change the systemic symptoms. And so again, your treatment needs to be individualized according to what you're presenting with.
Great. There's been another good one. So is there any research being done in Australia into quicker or less invasive methods of diagnosis?
Yeah, I mean, there's research going on in endometriosis spheres all over the world, but one of the things which is really wonderful about Australia is that we are actually quite advanced in some of the areas of endometriosis, and certainly in terms of things like the government recognition of endometriosis and the funding that has come through in the past few years for research, which is really exciting. There's a lot of research going on looking at, can we get what we call a biomarker for endometriosis. So that would be, can you go and have a blood test and you find a marker and that will say yes or no, you have endometriosis. Now, we don't have it yet, unfortunately, but there is research going on at the moment in a number of centres of Australia and worldwide, looking to see, can we actually find something that will give people a way of having an early diagnosis and a non-invasive diagnosis. We don't have it yet. I think the best next best thing that we've got that certainly we're getting more information from are those ultrasounds that I was talking about earlier. Some people will hear about MRI scanning for endometriosis as well, and we don't do that very frequently in Australia because we have such good ultrasound services available for looking at endometriosis. And when they compare the two, again, they're about the same. Diagnosis with MRI and diagnosis with very good endometriosis scanning are about equal. But in some countries, they preferentially divert people towards having an MRI. So there's a lot of research going into it. We're not quite there yet, but hopefully, you know, in the not too distant future, we will be able to have something where we can look into, you know, a blood test that would diagnose it.
Yeah, we're trying really hard. It will be a game changer, but we're trying really hard. Some people look at, just to add to Erin's point, there are some current tests that might, I think, you know, previously we used as a marker to look for endometriosis. So there's a blood test that looks for changes in the inner lining of your abdomen. We tend not to use that one because it's so non-specific, and it can also be up with things like cancers and things like that. So sometimes we end up leading to unnecessary investigation and people ending up with surgery they don't need to have just because the marker is up. That marker can be up if you've got any inflammation in your tummy. So if you've had a bit of, you know, gastroenteritis or something like that, that will put it up as well. So that test, which is some people used to do, we don't find it specific enough, and that's part of the challenge with the test. We want something that's going to be good enough to detect it, but not something that's going to lead people to have all these unnecessary surgeries or investigations, and that's trying to tailor that marker, finding that right marker.
Great. I'm conscious of us going over time, so I do think there's maybe one more question that's come through on both areas, but again, it's broad, but questions asking about the young women and teenagers and starting the process for them, essentially what you would recommend.
I think, I mean, always the start of the journey is going to be with a GP, and I think certainly finding a good GP who deals with women's health and who, you know, as Jason alluded to, there are actually a number of endometriosis specific GP centres that have been developed. The government's put some funding into that, so there are those areas out there, but also, you know, a good GP should be able to help that pathway along in terms of recognising that periods that incapacitate a teenager and mean that they can't attend school, they can't do their sport, they can't you know, go to enjoy the parties that they want to enjoy, that's not normal. Teenagers shouldn't have to go through that. They shouldn't have to live with that and put up with it. And there are lots of different things that we can try. And often we might start with some hormonal treatment options for teenagers, but there are certainly lots of things that we can look into. So the starting point is always, I guess, a good GP who can then either initiate management, because a lot of GPs are becoming better at starting the process in terms of management of endometriosis, but at the very least refer on, and you know, those teens can be seen in one of our clinics and we can start management, because if we start management early, not only do we hope that we're going to restrict the development of the disease over time, but some of the chronic nervous system changes that are established are really based on even those early years of having a monthly debilitating episode of pain. And that's going to set up that teenager for potentially issues down the track. So if we can intervene early and we can manage symptoms early, then we might be able to avoid some of those later issues, or at least to the same extent.
And it's not just the doctors you're seeing. I think that to speak to that changes to your pain nervous system as well, it's also in the setting where we run the pain service, the common story here is about not being recognised, not being listened to, and that invalidation. And we know that might come from schools, it might come from friends, it might come from family, and that's hard. And talking about this sort of thing can sometimes be triggering for some people. And I'm not trying to overemphasize it, but we do know that people who had early life adversity, and that might include a story of invalidation around their needs, can lead to downstream effects in terms of the way in how they not just manage pain, but manage life as well. And so seeking that help and finding your network that may be medical and maybe non-medical is really important. And if you're not being able to get that, you have the right to be heard, and that's important as well.
Yeah, and we certainly, you know, that in terms of management, there's we certainly still in young people aren't going to necessarily opt for a surgical approach first. We're going to look at that whole picture, and again, part of what we're wanting to try and avoid is that those long-term sequelae. So sometimes surgery early on isn't necessarily the best option either, but being listened to and having all of those options available to you, and making you feel empowered that you're making the decision with the information that's giving is really what we're hoping to achieve.
Well, I think this is probably a good point to put a full stop at the end of the evening. It's been absolutely amazing to be able to pick both your brains, Jason and Erin. There's been so many amazing questions that have come through, and we're so grateful for your time. We know how busy you both are, and yeah, on behalf of everyone at the Foundation and everyone else that's attended here tonight, thank you so much.
You're welcome. It's been a pleasure. Thanks everyone for your time.
Thank you.
Thanks everyone.